In this video series, we will be discussing about the biomechanics of the vertebral column. So by the end of this series, we will be able to understand the introduction or the typical vertebrae, about the intervertebral disc, about the different articulations present in the intervertebral column, and what are the different ligaments and joint capsules present in the intervertebral columns, and what are the regional differences, kinetics and kinematics of your cervical spine, kinetics and kinematics of your thoracic spine, kinetics and kinematics of your lumbar spine, and kinetics and kinematics of your sacral region, and what are the different effects of injuries, and what are the different effects of aging over the intervertebral column. So coming to the introduction, so the basic skeletal system has been classified into two different regions or two different parts. That is the axial skeleton and appendicular skeleton. Axial skeleton consists of 80 bones and appendicular skeleton consists of 126 bones. So your vertebral column will be coming, or vertebral column will be coming under the axial skeleton. And next is the different terminologies or relative locations or region within the axial skeleton. So first terminology is your posterior, that is synonymous to your dorsal, and that is defined as the back of the body. So anterior means ventral, that is defined as the front of the body. Medial, that is defined as the midline of the body. Lateral, that is divided away from the midline of the body. Superior, synonymous with the cranial, that is defined as the head or top of the body. Inferior, that is the caudal or tail part, and that is defined as the bottom of the body. So coming to the introduction of the vertebral column, the vertebral column resembles like a curved rod and composed of 33 vertebrae and 23 intervertebral discs, and it has been divided into 5 different regions. That includes your cervical region, which consists of 7 vertebrae. Second region is your thoracic region, that consists of 12 vertebrae. Third region is your lumbar region, that consists of 5 vertebrae. And fourth region is your sacrum, that is fused, and that consists of 5 vertebrae. These 5 vertebrae will be in a fused manner. And fifth region is your coccygeal region, that consists of 4 vertebrae. Similar to your sacral region, these 4 vertebrae in the coccygeal region is also in a fused manner. The vertebra increase in size from the cervical region to the lumbar regions, and then decrease in size from the sacral region to the coccygeal regions. So this means that higher compressive load or compressive stress will be over your lumbar region because of the increased size of the increased size of your vertebral bodies as well as your intervertebral disc. So these are the different regions of the vertebral columns. The first region, that is your cervical region, that consists of 7 vertebrae. Second region is the thoracic region, otherwise known as dorsal region or dorsal vertebrae, which consists of 12 bones. And third region is your lumbar region, that consists of 5 vertebrae, and fourth region is your sacral region, that consists of 5 vertebrae that in a fused manner, and fifth region is your coccygeal vertebrae, that consists of 4 bones that too in a fused manner like your sacral vertebrae. So coming to the curves, primary and secondary curves of the vertebral columns, there are 2 curves, that is the primary curves, so that retain the original posterior convexity throughout the life. So that is known as the primary curves. So that primary curves includes your thoracic curve and the sacral curve, whereas the other 2 curves, that is the cervical and lumbar, that shows a reversal of the original posterior convexity, that is known as they are concave in structure, that is known as secondary curves. So primary curves includes your thoracic and sacral region, and your secondary curves includes your cervical and lumbar region. And the curves that have a posterior convexity and anterior concavity are referred to as kyphotic curves. So primary curves is otherwise known as kyphotic curves, and the secondary curves is otherwise known as lordotic curves, because in lordotic curve they will be having posterior concavity and anterior convexity. So you can see here in cervical and lumbar region they will be having posterior concavity and anterior convexity. But in the thoracic and sacral region, they will be having anterior concavity and posterior convexity. So this is the difference between the primary and secondary curves. So coming to the typical vertebrate, the structure of a typical vertebrate consists of two parts, two major parts that includes your vertebral body and the vertebral or neural arch. The vertebral body is designed to be the weight-bearing structure of the spinal column. In order to minimize the weight of the vertebrae and allow dynamic load bearing, the vertebral body is formed by a shell of cortical bone surrounding a cancellous cavity. So this is not a solid block of bone. So this is just a shell of cortical bone surrounded by a cancellous cavity. The cortical shell is reinforced by trabeculae in the cancellous bone, which help resist the compressive forces. The compressive load appearing on the vertebral body or vertebral column has been resisted by this particular structure that is known as the trabecular system in the cancellous bone. So this is the part of a vertebral column, that is a typical vertebrae. So it includes your vertebral body and classified into neural arch. So the entire typical vertebra has been classified into two parts, vertebral body and the neural arch. The neural arch is further classified into pedicles and posterior elements. The posterior elements is again classified into lamina, transverse process, spinous process. So all these processes. So this is the trabecular system or the internal architecture of the vertebral body. So or the vertebral column. The various trabeculae are arranged along the line of force transmissions. This particular trabecular system are responsible for maintaining or controlling the compressive forces acting on the vertebral column. So this is the vertical trabecula of the vertebral bodies are arranged to resist the compressive loading. The neural arch is again further divided into pedicles and the posterior elements. The functions of the pedicles is to transmit the tension and bending forces from the posterior elements to the vertebral bodies. Pedicles increases in size from the cervical to lumbar regions. The remaining posterior elements are the lamina, articular process, spinous process, and the transverse process. The lamina are centrally placed and serves as an origination point for the rest of the posterior elements. The lamina are thin, vertically oriented pieces of bones that serves as the roof to the neural arch, which protects the spinal cord. In addition, the lamina transmit forces from the posterior elements to the pedicles and through them to the vertebral bodies. So lamina will be transmitting the forces from the posterior elements to the pedicles and to the finally to the vertebral bodies. So it acts like a bridge for the force transmission. So this force transfer occurs through a region of the lamina called the pars interarticularis. So pars interarticularis is a region situated or located in the lamina that will be helpful for force transferring from the posterior elements to the pedicles to the vertebral body. The pars interarticularis is the portion of the lamina that is between the superior and inferior articular process. So by the name itself, interarticularis. So it is located by the name itself. We can able to find that it is located somewhere in between the superior and inferior articular processes, and they are subjected to bending forces that are transmitted from the vertically oriented lamina to the more horizontally oriented pedicles. They are most developed in the lumbar spine, where the forces are greatest in the magnitude. In the typical vertebra, the spinous process and the two transverse processes are the sites for muscular attachments and serve to increase the lever arm for the muscles of the vertebral column. The articular process consists of two superior and inferior facets for articulation with the facets from the cranial and caudal vertebra, respectively. So coming to the intervertebral disc, the intervertebral disc has two principal functions. First function is to separate the two vertebral bodies, thereby increasing the available motions. So this intervertebral disc is responsible for increasing the range of motion within the intervertebral joints. And second function is to transmit the load from one vertebral body to the next. So it acts like a shock absorber and it resists the compressive loading over the intervertebral body. So therefore, the size of the intervertebral disc is related to both the amount of motions as well as the magnitude of the load that must be transmitted. So the intervertebral disc, which makes up to 20 to 33% of the length of the vertebral column, it increases. The intervertebral disc size will be getting increased from the upper region to the lower region. That is the cervical region to the lumbar regions. That means in the cervical region, the intervertebral disc will be small comparing to the lumbar region. Whereas in lumbar region, intervertebral disc size will be higher or more because of the increased weight bearing or the increased loading of the lumbar region. The disc thickness also varies approximately 3 mm in the cervical region, whereas the weight bearing loads are the lowest, to about 9 mm in the lumbar region, where the weight bearing loads are highest. So the cervical region only 3 mm in disc thickness is there, and comparative to the lumbar region, because the weight bearing is highest in the lumbar region. So in lumbar region, the disc thickness will be 9 mm. The intervertebral discs are composed of three parts, namely nucleus pulposus, annulus fibrosus, and vertebral end plate. Nucleus pulposus is a gelatinous mass, whereas annulus fibrosus is a fibrous outer ring, and vertebral end plate is a cartilaginous layer covering the superior and inferior surface of the disc, separating it from the cancellous bone of the vertebral bodies above and below. So this is the coronal section of the intervertebral disc, and this is the transverse section of the intervertebral disc. So in this, you can able to see the outer annulus fibrosus, inner nucleus pulposus, and the vertebral end plate on both the upper and lower sides of the intervertebral disc. So nucleus pulposus will be in a gelatinous structure, and this will be in a thickened-like structure. That is the annulus fibrosus. Coming to the nucleus pulposus, the nucleus pulposus is 70 to 90% of water, depending on the age and time of the day. The proteoglycans make up approximately 65% of the dry weight and have the ability to attract water molecules because of the presence of glycosaminoglycans. Because of the presence of glycosaminoglycans, they are having high water content. Collagen fibers contributes to about 50 to 20% of the dry weight, and it is also composed of collagen, chondrocytes, elastin fibers, proteins, and proteolytic enzymes. The nucleus pulposus has both type 1 and type 2 collagen, in which the type 2 collagen are more in the nucleus pulposus. And the nucleus pulposus has been frequently likened to be a water balloon. So it is almost similar like a water balloon. When compressed, it deforms, and the increased pressure stretches the walls of the nucleus pulposus in all directions. So during compressive loading, because of the increased pressure in the intervertebral disc, this nucleus pulposus will be stretching. The walls of the nucleus pulposus will be stretching in all directions, in all the four directions. So this is the loading. So you can able to see this is the normal intervertebral disc, and this is the intervertebral disc during an axial compression, in which the nucleus pulposus is loading in all the direction or compressing in all the directions. Next part of the intervertebral disc is the annulus fibrosus. In general, the annulus fibrosus is 60 to 70% of water, like the nucleus pulposus, depending on age and time of the day. Collagen fibers make up to 50 to 60% of the dry weight, with proteoglycans contribute only 20% of the dry weight. Clearly, the relative proportions of this component are different from the proportions in the nucleus pulposus, reflecting the difference in structure. So, annulus fibrosus is almost like a dry weight, and nucleus pulposus is almost like a watery structure. The remainder of the dry weight is made up of approximately 10% of the elastin fibers, such as the fibroblasts and the chondrocytes. Type 1 and type 2 collagen are present in the annulus fibrosus. They resist greater proportions of the tensile forces. So annulus fibrosus is responsible for resisting the greater portion or the greater proportions of the tensile forces. Next part of the intervertebral disc is the vertebral end plates. The vertebral end plates are layers of cartilage that is around 0 to 6 to 1 mm thick. The vertebral end plates consist of proteoglycans, collagen, water, and cartilage cells. There is a higher proportion of water and proteoglycans closest to the nucleus pulposus, and a higher proportion of collagen closest to the annulus fibrosus, and the subchondral bone to the of the vertebral body. The cartilage of the vertebral end plates is both hyaline as well as in fibrocartilaginous in structure. So that means the vertebral end plates consist of both the hyaline cartilage as well as the fibrocartilage. So hyaline cartilage is present closest to the vertebral body and is found mainly in the younger age groups. And fibrocartilage is present closest to the nucleus pulposus, and with increasing age, this becomes the major components of the vertebral end plates, with little or no hyaline cartilage remaining, reflecting the need to tolerate high compressive forces. So during the younger age, hyaline cartilage is present, and once the person is getting age or increased age, the fibrocartilage will be the composition of fibrocartilage will be predominating with the hyaline cartilage, and during your aging process, so the fibrocartilage will be more. So that is responsible for tolerating the high compressive forces over the vertebral column. Coming to the innervation and nutrition of the intervertebral discs. So they are innervated in the outer one-third to half of the fibers of the annulus fibrosus. In the cervical and lumbar regions, the intervertebral discs are innervated by branches from the vertebral and sinovertebral nerves. The sinovertebral nerves also innervates the peridiscal connective tissues and specific ligaments associated with the vertebral column. The intervertebral discs do not receive blood supply from any major arterial branches. The metaphyseal arteries from a dense capillary plexus in the base of the end plate cartilage and the subchondral bone deep to the end plate, and the small branches from these metaphyseal arteries supply the outer surface of the annulus fibrosus. So the outer surface of the annulus fibrosus is supplied by your metaphyseal arteries. The remainder of the disc, so except the outer surface, remaining part of the entire intervertebral disc receives its nutrition via diffusion. Coming to the articulations of the vertebral columns, there are two main types of articulations found in the vertebral columns. They are interbody articulations. That is a cartilaginous type of joints that is located between the two intervertebral bodies. And next articulations is the zygapophyseal articulations, otherwise known as apophyseal articulations or facetal articulations. This zygapophyseal or apophyseal articulations is otherwise known as facetal joints. These interbody articulations is known as intervertebral joints. And this zygapophyseal or articulations or apophyseal articulations is a synovial type joints. Synovial joints also are present where the vertebral column articulates with the ribs, with the skull, and with the pelvis at the sacroiliac joints. So coming to the first articulations, that is the interbody joints. So these available movements at the interbody joints includes your sliding, distraction, compression, and rotations. Rotation is otherwise known as tilting or rocking motions in the spine. Sliding motions occurs in the following directions, that is anterior to posterior sliding, medial to lateral sliding, or torsional sliding. Tilt motions can occur in anterior to posterior directions or in the lateral directions. These motions, together with distraction and compression, constitute of 6 degrees of freedom in the interbody joints. The amount of each of these motions are small and vary by region according to the structural differences in the disc and the vertebral bodies as well as the ligamentous supports. In addition, the apophyseal joints influence the total available motions of the interbody joints. The next articulation is known as the zygapophyseal articulations. These are composed of the articulations between the right and left superior articular faces of a vertebra and the right and left inferior faces of the adjacent cranial vertebra. The zygapophyseal joints are diarthrodial, that is the synovial joints and having regional variations in structure. The structure are most likely involved in protecting the articular surfaces that are exposed during flexion and extension of the vertebral column. Next, coming to the ligaments and joint capsules of the vertebral columns. The ligament system of the vertebral column is extensive and exhibits considerable regional variability. The six main ligaments that are associated with the intervertebral and zygapophyseal joints includes your anterior longitudinal ligament, posterior longitudinal ligament, ligamentum flavum, interspinous ligament, supraspinous ligament, and intertransverse ligament. So first is the anterior and posterior longitudinal ligament. The anterior longitudinal ligament and the posterior longitudinal ligament are associated with the interbody joints. That means they are attached in between the two intervertebral bodies. The anterior longitudinal ligament runs along the anterior and lateral surface of the vertebral bodies from the sacrum bone to the second cervical vertebrae. From the second vertebral to the occiput, it will be continuous or extended as the anterior occipital and the anterior atlantoaxial ligaments. That means the extension of this ligament, extension of the anterior longitudinal ligament above the C2, second vertebra, second cervical vertebra, is known as your anterior atlanto-occipital and anterior atlantoaxial ligaments. The anterior longitudinal ligament has two layers like your posterior longitudinal ligaments, and that are made up of thick bundles of the collagen fibers. So these two layers includes your superficial layer and the deep fibers or deep layers. The fibers in the superficial layers are long and bridge several vertebrae, whereas the deep fibers or deep layers are short and run between single pairs of vertebrae. So that means your superficial layer will be connecting the several vertebrae and the deep layers or deep fibers will be connecting single vertebrae. The deep fibers blend with the fibers of annulus fibrosis and reinforces the anterolateral portions of the intervertebral disc and the anterior interbody joints. So these deep fibers later will be blending with the fibers of the annulus fibrosis and reinforces the anterolateral portion of the intervertebral disc as well as the anterior interbody joints. So this anterior longitudinal ligament will be increasing in thickness and width from lower thoracic vertebrae to the L4, L5S1 vertebrae. The tensile strength of the ligament is greatest in the higher cervical, lower thoracic, and the lumbar regions, with the greatest strength being in the lumbar region. It is reported to be twice as strong as the posterior longitudinal ligament. This is one of the important points because in extension, this is the only ligament that will be helpful for protecting the intervertebral column. So this anterior longitudinal ligament is twice as strong as the posterior longitudinal ligament. This ligament is compressed in flexion. During flexion, this ligament will be getting compressed, and during extension, this ligament will be getting stretched. So it may become slack in the neutral position of the spine when the normal height of the disc is reduced, as might occur when the nucleus pulposus is degenerated. So this particular anterior longitudinal ligament will be slack in the neutral position. So this is the diagrammatic representation during your flexion as well as your extension. During flexion of your spine, you can see here the anterior longitudinal ligament is getting compressed and your posterior stretches will be getting stretched. So similarly in extension, the anterior longitudinal ligament will be getting stretched and preventing the excessive and hyperextension of your spine. So this is the only ligament that will be working during the extension. So that is the main reason why this anterior longitudinal ligament is twice as strong as the posterior longitudinal ligament. Coming to the posterior longitudinal ligament, it runs on the posterior aspect of the vertebral bodies from C2 to sacrum. Anterior longitudinal ligament has been running from down to bottom, that is from the sacrum to second cervical vertebra. But in posterior longitudinal ligament, this will be running from top to bottom, that is from the second cervical vertebra to the sacral region, and forms the ventral surface of the vertebral canal. It also consists of two layers, that is the superficial layer and the deep layer. Superficial layer fibers spans or getting attached with the several vertebrae, in the deep layer, these fibers extend only to one adjacent vertebrae, interlacing with the outer layers of the annulus fibrosis and attaching to the margins of the vertebral end plates in a manner that varies from segment to segment. Superiorly, this ligament becomes the tectorial membrane. So the extension of your posterior longitudinal ligament above the second cervical vertebra is known as your tectorial membrane. So that will be running from the second cervical vertebra to the occipital region. In the lumbar region, this ligament narrows to a thin ribbon that provides little support for the interbody joints. The posterior longitudinal ligament is stretched in flexion and slack in the extension. So in this diagram, you can able to see here. During flexion, the posterior longitudinal ligament along with the other ligaments will be getting stretched, and during extension, this posterior longitudinal ligament will be getting slack. Next ligament is your ligamentum flavum. The ligamentum flavum is a thick elastic ligament that connects lamina to lamina from C2 to sacrum and forms the smooth posterior surface of the vertebral canal. Some fibers extend laterally to cover the articular capsules of the facetal joints. From C2 to occiput, this ligament continues as the posterior atlanto-occipital and posterior atlanto-axial membranes. This ligamentum flavum is strongest in the lower thoracic region and weakest in the mid-cervical region. Although the highest strain in this ligament occurs during flexion, when the ligament is stretched, this ligament is under constant tension even when the spine is in a neutral position because of its elastic nature. Since this contains a higher elastin component, ligamentum flavum is elastic in nature. So this highly elastic nature serves two purposes. First purpose is it creates a continuous compressive force on the disc, which causes the interdiscal pressure to remain high. The raised pressure in the disc makes the disc stiffer and thus better able to provide support for the spine even in the neutral position. Second purpose is a highly elastic ligament in this location is advantageous because the ligament will not buckle on itself during movements. So because of the highly elastic elastic component in this particular ligament, this ligament will not get buckled during the motions. If the ligament did not buckle on itself, it would compress the spinal cord in the vertebral canal, especially without any movement into flexion. So next ligament is known as your interspinous ligament. That means in between the spinous process, adjacent spinous process. The interspinous ligament connects the spinous process of adjacent vertebra. It is a fibrous sheet consists of type 1 collagen, proteoglycans, and profuse elastin fibers. The interspinous ligament, along with the supraspinous ligament, is the first to get damaged during the excessive flexion or hyperflexion activities. So you can able to rewrite it as like the function like this is the during hyperflexion or excessive hyperflexion will be prevented by this interspinous ligament and the supraspinous ligament. So this is the main function of this interspinous ligament. The interspinous ligament is innervated by the medial branches of dorsal rami and is thought to be a possible source of low back pain. So once the interspinous ligament is getting weak means you may cause the low back pain. So this is one of the culprit for your low back pain. The interspinous ligament has been found to contribute to the lumbar spine stability, and this interspinous ligament will be getting degenerated with aging. Next ligament is your supraspinous ligament. It's a strong cord-like structure that connects the tips of the spinous process from the 7th cervical vertebrae to the L3 or L4 vertebrae. The fibers of this ligament become intestine in the lumbar area where they merge with the thoracolumbar fascia and the insertions of the lumbar muscles. In the cervical region, the ligament becomes the ligamentum nuchae. The supraspinous ligament, like the interspinous ligament, is stretched in flexion and its fibers resist separation of the spinous process during forward flexion. During hyperflexion, the supraspinous ligament and the interspinous ligament are the first to fail. So like I already mentioned in the previous slides in the interspinous ligament slides. The same function during hyperflexion, both these ligaments will be getting damaged. The supraspinous ligament contains mechanoreceptors, and deformation of this ligament appears to play a role in the recruitment of spinal stabilizers such as multifidus muscles. Next ligament is your intertransverse ligaments. So that means the ligament that gets attached in between the transverse process. One transverse process to the another transverse process. The structure of the paired intertransverse ligament is extremely variable. The ligaments pass between the transverse process and attach the deep muscles of the back. In the cervical region, only a few fibers of the ligaments are found. In the thoracic region, the ligament consists of a few barely discernible fibers that blend with the adjacent muscles. In the lumbar region, the ligament consists of broad sheets of connective tissues that resemble a membrane. The membranous fibers of the ligament forms the part of the thoracolumbar fascia. The ligaments are alternately stretched and compressed during the lateral bending. The ligaments on the right side are stretched and offer resistance during lateral bending to the left, whereas the ligaments on the left side are slack and compressed during the motions. This diagram you can able to see. This is the left lateral bending or left lateral flexion. In this, during left lateral flexion, the right side intertransverse ligament will be getting stretched, and the left side or the movement towards the concave side, the concavity side intertransverse ligament will be slack. So this is how the opposite side. So during lateral flexion to the left side, the ligaments on the right side will be preventing the excessive lateral flexion or the excessive lateral bending of the spine towards the left. So this is the ligamentum nuchae. So this is one of the prominent ligament. So next one is the zygapophyseal joint capsules. The zygapophyseal joint capsules assist the ligaments in providing the limitations to motion and stability for the vertebral columns. So this means not only your ligaments is providing stability to the particular intervertebral column, your joint capsules or your fascial joint capsules are also responsible for limiting the range of motion as well as providing the stability to the vertebral columns. The role of the joint capsules also vary by region. In the cervical spine, the fascial joint capsules, although lax, provides the primary soft tissue restraint to the axial rotation and lateral bending, but they will provide little restraint to the flexion and extension. So in the cervical spine, this particular joint capsules will be restricting the rotation motion as well as the lateral flexion motions, but they also provide restrictions to the flexion and extension, but in a minimal manner. The zygapophyseal joint capsules on the lumbar spine, in addition to the annular fibers, also provide primary restriction to the axial rotation, but those on the thoracic spine do not. The capsules are strongest in the thoracolumbar region and at the cervicothoracic junction sides, where the spinal configuration changes from a kyphotic to lordotic curve and from a lordotic to kyphotic curve respectively, and the potential exists for excessive stress in these areas. So in these two different region junctions, like your thoracolumbar junction as well as your cervicothoracic junctions, since there is a change in the spinal configuration from this particular kyphotic to lordotic curve or from the lordotic to kyphotic curves, so these particular capsules are strongest in these particular junctions because of the excessive stress occurring in the particular regions. So these capsules are more strong in the particular junction sites of the vertebral column. The joint capsules like the supraspinous and interspinous ligaments are vulnerable to hyperflexion, especially in the lumbar regions. So during the hyperflexion motions, these particular ligaments, supraspinous ligament and the interspinous ligaments, is the first one to fail along with your joint capsules. So all these ligaments as well as your capsule will be responsible for preventing the excessive hyperflexion motions in the lumbar spine. It has been suggested that the joint capsules in the lumbar region provide more restraint to forward flexion than any on the posterior ligaments because they fail after the supraspinous and interspinous ligament when the spine is hyperflexed. So when the spine is hyperflexed, these two ligaments will be first getting failed, and after that, these joint capsules will be getting failed. So these three stretches, the joint capsule, supraspinous ligament, and your interspinous ligament, is the primary restraints of for your hyperflexion. Or in another sense, the hyperflexion will be prevented by these particular three structures. In this video, we will be discussing about the kinetics and kinematics of the vertebral column. So first is about the kinematics. So kinematics, as you know, it is the it describes about the motions that occurs in the particular joints, and kinetics is about the forces that acts on the particular motions. And coming to the kinematics, the motions available to the vertebral column as a whole are flexion, extension, lateral flexion, and rotation. So before going to the kinematics, we need to discuss something known as coupling. So coupling is defined as the consistent association of one motion about an axis with another motion around a different axis. So it appears that pure lateral flexion and pure rotation do not occur in any region of the spine. In order for either motion to occur, at least some of the other motion must occur as well. So coupling patterns as well as the types and amount of motions that are available are complex, and it differs from region to region, and it depends upon the spinal posture and the curves and the orientation of the articulating facets, the fluidity, elasticity, and thickness of the intervertebral disc, the extensibility of the muscles, ligaments, and joint capsules. So all these factors are responsible for the coupling patterns. Motions at the interbody joints and cyclophacial joints are interdependent. The amount of motion available is determined primarily by the size of the disc, whereas the direction of the motion is determined primarily by the orientation of the faces. The direction of motion is primarily determined by the orientation of the facets. So the intervertebral disc increases movement between the two adjacent vertebrae. If the vertebrae were to lay flat against each other, the movement between them were limited to translation alone. So in this diagram, so we can able to see that this is the motion. This is the motion like your flexion motion, and so this is the two intervertebral bodies. In between this board is known as your intervertebral. This particular structure is known as your intervertebral disc. And this image, the B section B image, is without the intervertebral disc. So without intervertebral disc, only the translation movement is possible. And with intervertebral disc, your translation as well as your bending motions will be possible. So if the vertebrae were to lay flat against each other, the movement between them would be limited to translation alone. The vertebrae are also allowed to rock or tilt on each other because the soft deformable disc is present in between them. These arrangements adds tremendous range of motion. The fibers of annulus fibrosis behaves as a ligamentous structure and acts as a restriction to the motions. So the annulus fibrosis will be limiting the range of motion, restricting the range of motion, as well as because of the add upon this intervertebral, because of the presence of this particular intervertebral disc, the range of motion of the vertebral joint is getting increased. The motions of flexion and extension occurs as a result of tilting and gliding of superior vertebra over the inferior vertebra. The nucleus pulposus act like a pivot, but is able to undergo greater distortion than a ball is because it behaves as a fluid. Because of the presence of the glycosaminoglycans and the proteoglycans, so it is almost watery in structure, and because of the fluid nature, this distortion will be in greater manner in the nucleus pulposus. Because of that, it acts like a pivot. Regardless of the magnitude of motion created by the ratio of the disc height to width, a gliding motion occurs at the interbody joints and the apophyseal joints. as the vertebral body tilts or rotates over the disc at the interbody joints. The orientation of the facetal surfaces, which varies from region to region, determines the direction of tilting and gliding within a particular region. If the superior and inferior facet surfaces of three adjacent vertebrae lies in the sagittal plane, the motions of flexion and extension are facilitated. On the other hand, if the facetal surfaces are directed in the frontal plane or placed in the frontal plane, the predominant motion that is allowed is lateral flexion. So this is a model highlighting the three functional components of the typical intervertebral junctions. So the transverse process, your transverse process and the spinous process, and the apophyseal joints or the facetal joints and the interbody joints. In between these interbody joints, you can able to see your intervertebral disc. And this is the axis of motion. And what are the structures? What are the more changes that occurs during the flexion? You can able to see here. Your structures that is present over your posterior aspect, that is your spinous process. In between your spinous process, your supraspinous and interspinous ligament will be getting stretched, and you can see here the anterior annulus fibrosis will be getting compressed, and the posterior annulus fibrosis will be getting stretched. So this is all about the motions during the flexion. This is just an example of what are the changes and what are the stretches present in the intervertebral column. And coming to the terminologies of osteokinematics, so you can see here the flexion and extension occurs in the sagittal plane, that is the mediolateral axis of rotation. And the other terminologies used for flexion and extension are your forward as well as your backward bending. And lateral flexion to right or left, that will be occurring in the frontal plane or coronal plane, and that will be occurring in the axis that is known as the anteroposterior axis. And the terminologies used are side bending to right or left. And next motions is your axial rotation to right or left, that will be happening in the horizontal plane and vertical axis. And the other terminologies used for axial rotation are your rotation as well as torsional movements. So first motion of kinematics is your flexion. In vertebral flexion, anterior tilting and gliding of the superior vertebra occur and causes widening of the intervertebral foramen and separation of the spinous process. Although the amount of tilting depends partly on the size of the disc, tension in the supraspinous and interspinous ligaments resists separation of the spinous process and thus limits the extent of flexion. That is, hyperflexion is prevented by these two ligaments along with your capsule, supraspinous ligament, interspinous ligament, as well as your capsule. Passive tension in the zygapophyseal joint capsules, ligamentum flavum, posterior longitudinal ligament, posterior annulus fibrosis, and back extensors also imposes control on excessive flexion. So excessive flexion is also prevented by these structures like your joint capsules, ligamentum flavum, posterior longitudinal ligament, posterior annulus fibrosis, and back extensors, along with your supraspinous and interspinous ligaments. With movement into flexion, the anterior portion of the annulus fibrosis is compressed and bulges anteriorly, while the posterior portion is stretched and resists the separation of the intervertebral bodies. So in this diagram, you can able to see here, during flexion, your anterior longitudinal ligament will be getting compressed, and your posterior stretches, all the ligaments will be getting stretched. And in the intervertebral disc, you can able to see here, the anterior annulus fibrosis will be getting compressed and bulged anteriorly, and the posterior annulus fibrosis will be getting stretched. And this all of these stretches of the over the posterior aspect of the vertebral column will be responsible for preventing the hyperflexion of the vertebral column. So during flexion, also the spinous process, the space between your spinous process will be getting increased. Excessive hyperflexion will be prevented by these particular ligaments that is attached over the spinous process, that is known as your interspinous ligament and your supraspinous ligaments. So this is about the particular disc structure. And anterior annulus fibrosus will be getting compressed as well as bulging anteriorly. Posterior annulus fibrosus will be getting stretch. So during extension, in extension there will be exactly opposite motions that is occurring for your flexion movement. So in extension, the posterior tilting and gliding of the superior vertebra occurs and causes narrowing of the intervertebral foramen, and the spinous process moves closer together. That is an approximation of your spinous process will be happening during your extension range of motion. And the amount of motion available in extension, in addition to be limited by the size of the disc, is limited by the bony contact of the spinous process during the approximation, and passive tension in the zygapophyseal joint capsules, anterior fibers of the annulus fibrosus, anterior trunk muscles, and the anterior longitudinal ligaments. This particular anterior longitudinal ligament is the only ligament that limits extension in the intervertebral column. So this is likely the reason that the ligament is so strong compared to posterior longitudinal ligaments. So in extension, you can see here the anterior longitudinal ligament will be stretched, and this, because of this stretch, it will prevent the excessive extension or your hyperextension of your spine. And all the other stretches will be getting slack. All the other stretches over your posterior aspect of your spine will be getting slacked. And anterior longitudinal ligament is the only ligament that will be responsible for preventing the excessive motions or hyper extension over your spine. That is the main reason why it is 2 times stronger than your posterior longitudinal ligaments. In extension, the posterior longitudinal ligament along with your other ligaments will be getting slack. And during extension, you can see here the posterior annulus fibrosus will be getting compressed and it will be bulging posteriorly, and your anterior annulus fibrosus will be getting stretched. And the third motion of your kinematics is your lateral flexion. In lateral flexion, the superior vertebra laterally tilts or rotates and translates over the adjacent vertebra below. So you can see here, during lateral flexion, there is not only the lateral flexion or lateral tilting occurs, there is some amount of rotation also happening during the lateral flexion. This particular phenomenon is known as your coupling motions. And the intervertebral foramen is widened on the side contralateral to the lateral flexion and narrowed on the ipsilateral side. On the same side, the intervertebral foramen will be getting narrowed, and on the opposite side, the intervertebral foramen will be getting widened. The annulus fibrosus is compressed on the concavity of the curve and stretched on the convexity of the curve. Passive tension in the annulus fibrosus, intertransverse ligaments, and the anterior and posterior trunk muscles on the convexity of the curve limits the lateral flexion. The excessive lateral flexion will be prevented by the passive tension in the annulus fibrosus, intertransverse ligaments, anterior and posterior trunk muscles. The direction of rotation that accompanies the lateral flexion differs slightly from region to region because of the orientation of the facets. So this is same thing, like because of the orientation of facets, the coupling motion also, the direction of motion also will be getting altered. So in this diagram, you can able to see here, this is the intertransverse ligament. So this is the lateral bending or lateral flexion towards your left side. During lateral flexion towards your left side, you can see here the intertransverse ligament of your opposite side or your contralateral side will be getting stretched, and the intertransverse ligament of your same side flexion, same side or your towards your concavity will be getting slacked. So the excessive lateral flexion towards your left side will be prevented by the intertransverse ligament and the muscular stretches over your right side or your convexity curve. So exactly opposite happens for your right lateral flexion also. The next motion is your rotation. Rotation is available in each spinal region, but due to the drastically different shapes of the apophyseal joints. The kinematics vary greatly by region. So just understand that there is no pure isolated lateral flexion or rotation happening in the spine. So during lateral flexion as well as your rotation, so during lateral flexion there will be some amount of rotation happening in the spine. This particular phenomena is known as your coupling motions. So coming to the summary of the stretches that prevent the particular motions of your vertebral column includes for flexion, the stretches that restricts or limit the motions are your ligamentum nuchae, interspinous and supraspinous ligament, ligamentum flavum, apophyseal joints, posterior annulus fibrosis, and the posterior longitudinal ligaments. And beyond the neutral extension or hyperextension will be prevented by your apophyseal joints, cervical viscera, that is your esophagus and the trachea, anterior annulus fibrosis, anterior longitudinal ligaments. And the axial rotation or rotation will be prevented by excessive axial rotation, will be prevented by your annulus fibrosis, apophyseal joints, alar ligaments. And the lateral flexion or lateral tilting will be prevented by your intertransverse ligaments, contralateral annulus fibrosis, apophyseal joints. So next is about the kinetics of your vertebral columns. The vertebral column is subjected to axial compression, tension, bending, torsion, and shearing stress. Not only during the normal activities, normal functional activities, but it also happens during the rest. So first is about the axial compression. So axial compression occurs as a result of force of gravity, ground reaction forces, forces produced by the ligaments and the muscular contractions. The disc and vertebral bodies resist most of the compressive force, but the neural arches and the zygapophyseal joints share some of the load in certain postures and during specific motions. The compressive load is transmitted from superior end plate to the inferior end plate through the trabecular bone of the vertebral body and the cortical shell. So in the previous video, we already discussed about the trabecular arrangement of bones, and during that time, we had discussed about the function of this particular trabecular over here in the vertebral bodies. So this will be helpful for transmitting the compressive load from the superior end plate to the inferior end plate. Depending on the posture and the region of the spine, the facetal joints or zygapophyseal joints carry 0 to 33% of the compression load. The spinous process also may share some of the load when the spine is in hyperextension. So during hyperextension, the spinous process are also responsible for sharing some of the compressive load. The nucleus pulposus acts as a ball of fluid that can be deformed by a compressive force. So during compression, the nucleus pulposus act like a ball and they will be dissipated. They will be getting compressed in all the directions. The pressure created in the nucleus pulposus is actually greater than the force of the applied load. When a weight is applied to the nucleus pulposus from above, the nucleus pulposus exhibits a swelling pressure and tries to expand outward towards the annulus fibrosis and the end plates. So when a compressive force is acting on the intervertebral disc, the nucleus pulposus will exhibit a swelling pressure and they will be trying to expand in all the directions. That is towards the annulus fibrosis and the end plates. In this diagram, you can able to see here, this is the normal spine without any axial compression. So this is the spine with axial compression, and you can see here the dissipation of forces or the compression of the annulus fibrosis in all directions. That is towards your annulus fibrosis and your vertebral end plates. This is the vertebral end plates, and this region is known as your annulus fibrosis. So the nucleus pulposus will be getting compressed in all directions towards either your annulus fibrosis as well as towards your vertebral end plates. As the nucleus pulposus attempts to distribute the pressure in all directions, stress is created in the annulus fibrosis and a central compressive loading occurs on the vertebral end plates. The force of the nucleus pulposus on the annulus fibrosis and of annulus fibrosis on the nucleus pulposus forms an interaction pair. Normally, the annulus fibrosus and the end plates are able to provide sufficient resistance to the swelling pressure in the nucleus pulposus to reach and maintain a state of equilibrium. The pressure exerted on the end plates is transmitted to the superior and inferior vertebral bodies. So in this diagram, you can able to see here, because of the compressive loading, there will be some dissipation of forces or compression of the nucleus pulposus in all directions towards the annulus fibrosus and the vertebral end plates. And from that, in order to become in a state of equilibrium, and because of that, there will be an exactly opposite force from that will be occurring from the annulus fibrosus towards the nucleus pulposus and from the vertebral end plates towards the nucleus pulposus. So by this, there will be a formation of interaction pair. So the force which is given exactly the amount of force which is given by the nucleus pulposus, the exactly opposite force will be given by the annulus fibrosus as well as your vertebral end plates. So finally, this will attain a state of equilibrium. So this particular phenomena is known as particular phenomena forms an interaction pair to maintain the particular structures, that is the intervertebral joint, in a state of equilibrium during your axial compression. The disc and trabecular bone are able to undergo a greater amount of deformation without failure than the cartilaginous end plates or cortical bone when subjected to axial compression. So the end plates are able to undergo the least amount of deformation, and therefore it will be the first to fail, that is fracture under higher compressive loading. The disc will be the last to fail or rupture. The intervertebral disc, like all viscoelastic materials, exhibit creep. This phenomena produces typical diurnal changes in the disc composition and function. So during axial compression, all these structure will be helpful for preventing the deformation, but there is some limit, and if it happens, if the compression force is beyond that normal limit, then the end plate, the vertebral end plate, will be the first structure to get fracture or to fail, and the disc, the vertebral intervertebral disc, will be the last to fail, that is in order to rupture. So when the intervertebral discs are subjected to a constant load, they exhibit creep. So creep is one of the property of your connective tissue. Under sustained compressive loading, such as that incurred in upright posture, the rise in the swelling pressure causes fluid to be expressed from the nucleus pulposus and the annulus fibrosus. The amount of fluid expressed from the disc depends both on the size of the load and duration of its applications. The expressed fluid is absorbed through the microscopic pores in the cartilaginous end plate. So during compressive loading, there will be swelling pressure. There will be a rise or increase in the swelling pressure. Because of that, the fluid will be coming out from the nucleus pulposus and the annulus fibrosus towards your cartilaginous end plates. So in the cartilaginous end plate, there will be some microscopic pores, and this express or the fluid that is coming from the nucleus pulposus and annulus fibrosus will be going or absorbed by the cartilaginous end plate through their microscopic pores. When the compressive forces on the disc are decreased, the disc will be imbibing the fluid back from the vertebral bodies. Once the compressive force has been reduced, this particular fluid that is gone towards the particular cartilaginous end plate will be coming back or imbibing back to the normal region, that is towards the nucleus pulposus and annulus fibrosus. The recovery of fluid that returns the disc to its original state explains why a person getting up from the bed is taller in the morning than in the evening. So this is one of the phenomena that occurs in the intervertebral column. So during standing, because of the compressive load, the fluid inside the annulus fibrosus as well as the nucleus pulposus will be coming out, and it will be going diffused towards the vertebral end plates. Because of that, there will be minor or slighter differences in the normal height of the person. Once the person takes rest at the night in the form of sleeping, there will be reduction in the compressive force. Because of that reduction in the compressive force, you can able to see in the morning there will be some height differences. The average variation in the height during the day has been demonstrated to be 19 mm with a loss of approximately 1.5 mm, that is almost 20% in the height from each of the lumbar intervertebral discs. So during daytime, so you can, because of the compressive force, axial compressive force in the even in the neutral spine, because of the active erect standing, there will be some approximately 20 percentage of the reduction in height of the intervertebral disc for each lumbar intervertebral disc. Running is a form of dynamic loading that decreases the disc height more rapidly than the static loading. The height of the vertebral column is a wide used indicator for a cumulative compression. The amount of compressive forces that act on the intervertebral spine or a vertebral column is can be found by using the height of the vertebral column. In a study involving 31 men, found that the men had a mean loss of 0.89 centimeter to 0.72 centimeter after a 6-mile run. So not only during standing, so running also leads to uh, increased compressive force over your vertebral column, and that will be leading to reduction in the height of the vertebral disc as well as your vertebral column. So next kinematics is your bending. So bending causes both compression and tension on the structures of the spine. In forward flexion, the anterior structures, that is the anterior portion of the disc, anterior ligaments and the anterior muscles are subjected to compression, and the posterior structures are subjected to tension or stretching. The resistance offered to the tensile forces by collagen fibers in the posterior outer annulus fibrosis, cytophyseal joint capsules, and the posterior ligaments help to limit the extremes of motion and this provides stability in flexions. Creep occurs when the vertebral column is subjected to sustained loading, such as might occur in the fully flexed posture, commonly assumed in gardening, or fully extended posture assumed in painting a ceiling. The resulting deformation, that is elongation or compression of supporting structures such as the ligaments, joint capsules, and intervertebral discs, leads to an increase in the range of motion beyond the normal limits and places the vertebral structures at risk of injury. If the creep deformation of tissues occurs within the toe region of stress strain curve, the structures will return to their original dimensions either minutes or hours after cessation of the activities. That is known as the elastic phase. And in extension, the posterior structures generally are either unloaded or subjected to compression, while the anterior structures are subjected to tension. In general, the resistance to extension is provided by the anterior outer fibers of the annulus fibrosis, the apophyseal joint capsules, passive tension in the anterior longitudinal ligament, and possibly by the contact of the spinous process. That is a bony contact between the one spinous process to the adjacent spinous process by the process known as approximation. In lateral bending, the ipsilateral side or the same side of the disc will be getting compressed. That is, in right lateral bending or right lateral flexion, the right side of the disc will be getting compressed and the outer fibers of the left side of the disc will be stretched. During right lateral flexion, the right side of the disc will be compressed and the left side of the disc will be stretched. As well as your other ligaments also, intertransverse ligament also will be getting compressed and stretched. Therefore, the contralateral fibers of the outer annulus fibrosis and the contralateral intertransverse ligament helps to provide stability during lateral bending too by resisting the extremes of motions. So during right side lateral bending or right side lateral flexion, the left side muscles as well as left side annulus fibrosis along with your left side intertransverse ligament will be helpful for preventing the extremes of the range of motion of the lateral flexion. Next kinetics is known as your torsion. The torsional forces are created during axial rotation that occurs as a part of the coupled motions that take place in the spine. The torsional stiffness in flexion and lateral bending of the upper thoracic region from T1 to T6 is similar, but torsional forces or torsional stiffness increases from T7 to T8 to L3 to L4. The lower thoracic as well as your lumbar region will be having increased torsional stiffness. Torsional stiffness is provided by the outer layers of the both vertebral bodies and the intervertebral disc and by the orientation of the facets. The outer shell of the cortical bone reinforces the trabecular bone and provides resistance to torsion. When the disc is subjected to torsion, half of the annulus fibrosis resists clockwise rotations, while fibers oriented in the opposite direction resist counterclockwise rotations. Has been suggested that the annulus fibrosis may be the most effective stretchers in the lumbar region for resisting the torsion. However, the risk of rupture of the disc fibers is increased when torsion, heavy axial compression, and forward bendings are combined. So these are the different translations and rotation of one vertebra in relations to the adjacent vertebrae. So the peak or in the first, that is the A, is known as your side to side translation or your gliding motions that is occurs in the frontal plane. The B diagram is your superior and inferior translations, that is the axial compression as well as axial distraction. And the C diagram is known as your anteroposterior or anterior and posterior translation that occurs in the sagittal plane. And the D diagram is the side to side rotation or tilting in the frontal plane that occurs around a anteroposterior axis. The fifth diagram is your rotation that is occurring in a transverse plane around a vertical axis. The sixth diagram that is the anteroposterior rotation or tilting that occurs in the sagittal plane around a frontal axis. So next one is your next kinetics is about the shearing force. The shearing force acts on the midplane of the disc and tend to cause each vertebra to undergo translation to move anteriorly, posteriorly, or from side to side in relation to the inferior vertebrae. So in the lumbar spine, the zygapophyseal joints resist some of the shearing force and the disc resists the remainder. The shearing force, excessive shearing force is resisted by your apophyseal joints as well as your intervertebral disc. When the load is sustained, the disc exhibits creep and the zygapophyseal joints may have to resist all of the shearing force. So during the excessive load or when the particular load is sustained, for example, if the person is doing a bending activity for a prolonged period of time, the normal function of the disc was to resist the shearing force, but during excessive bending motion, the disc will be going and this will be exhibiting a creep phenomena. That is one of the property of the connective tissue, and because of this particular function or happening, the apophyseal joints or the zygapophyseal joint have to resist all of the shearing forces. A sagittal plane orientation of the lumbar facet favors the motions of your flexion as well as your extension, and the frontal plane alignment or orientation of the thoracic facets favors the lateral flexion. So this means the motions, the direction of motion is determined by the direction or orientation of your facets. So if the facet is oriented in a sagittal plane manner, so therefore the motions of flexion and extension will be predominated in the lumbar spine, and in the thoracic spine the facet orientation is in the frontal plane alignment, and because of this alignment of or orientation of facets in the frontal plane in the thoracic spine, therefore it will be the main motion that occurs in the thoracic spine will be your lateral flexion. So by this, we are concluding the kinetics and kinematics introduction part of your vertebral column, biomechanics of your vertebral column. So kindly do subscribe and share this to your friends. Thank you.